So, good evening to everyone. And today we're going to discuss two topics. One is going to be continuing our toxicology series, and that will be on digoxin toxicity. And the other one is going to be on an article that was published on a new classification for permanent molecules. It's not really that radical a change, but it was kind of interesting thought. So I thought I'd share that. So initially, we'll kick off with digoxin. So, what is digoxin? Digoxin is basically a cardiac glycoside, and this is related to a lot of naturally occurring compounds like foxglove, which is one of the plants from which it is derived. Then we have other things like oleander, lily of the valley, etc. So, it is derived from naturally occurring compounds. And how does it act? Basically, it will inhibit the sodium potassium ATPase. And what this sodium potassium ATPase normally does is that it pumps sodium out of the cell and pumps potassium into the cell. So if you block that, basically you will have a build up of sodium into the cell that will promote this sodium calcium exchanger, and that becoming more active will lead to more calcium into the cell, which will bind its proponency, leading to increased ionotropy. So it will increase the contractility, basically. And understanding this will also make you understand why in digoxin toxicity you can have things like hyperkalemia, because less potassium will be getting into the cells, and a potassium more than 5.5 in the context of digoxin toxicity is actually a poor prognostic marker. So it inhibits sodium potassium ATPase from increases intracellular sodium, then which will stimulate the exchanger, and that will increase the intracellular calcium while increasing the extracellular potassium. So basically, there are three important effects that this has clinically that will increase the ionotropy. That is why it is used in conditions like heart failure with atrial fibrillation. So it will increase the ionotropy. It will decrease the refractory period. So it will actually lead to a shortened QT interval. And it will increase the delayed after depolarization. We can lead to things like more premature ventricular contractions and certain types of arrhythmias. So basically, so it increases the vagal tone. So it will decrease the conduction of the SA node and AB node. That this will lead to AB nodal blocks of various types. But in toxicity, it will actually it can increase the sympathetic tone. In advanced heart failure, it causes some degree of vasoconstriction as well. So coming to the pharmacokinetics, it is the bioavailability is around 60 to 80%, and it has good oral absorption. And this is something that we actually use when we are calculating the number of vials of the digoxin antibody required as well. So peak levels are usually occur around 6 hours after an injection, and it has a large volume of distribution. So whenever you read that a drug has a large volume of distribution, the immediate thing that should come into your mind is that dialysis is not going to be useful for removing this particular drug in overdose. So dialysis is not having much of a role in digoxin overdose. It is metabolized in the liver and is predominantly excreted through the kidneys. And it has a very long half-life, around 30 to 40 hours, but it can be prolonged in renal failure also. So it has a lot of drug interactions, and you have to understand that the excretion through the into the urine is facilitated by P glycoprotein. So inhibitors of P glycoprotein will increase digoxin levels, and inducers of P glycoprotein will decrease digoxin levels. So what are some drugs that can actually inhibit P glycoprotein and increase digoxin levels? You have important things. Your antiarrhythmics like amiodarone can do this. Something to keep in mind, because sometimes we do combine both of these drugs together when patient atrial fibrillation. Verapamil can do this. Your macrolides can do this, and as antifungals can do this. So these are some of the commonly used drugs that can actually increase your digoxin levels. Things that can decrease your digoxin levels, that is the things that induce your P glycoprotein is some antiepileptics like carbamazepine, phosphonate, phenobarbital, and your antituberculosis drug, rifampin. So all of these medications can decrease your digoxin levels. And coming to an important concept, that is what digoxin does to the ECG. So in this topic, you have to understand two things. There are some things that digoxin will do even at normal therapeutic levels or to the ECG. And there is something that digoxin will do to the ECG when it is an overdose. And you should not actually confuse both of them. Digoxin effect is basically this Salvador Dali kind of ST depression. So it looks like this guy's mustache here. So this kind of ST depression on the ECG. So, or a reverse tick appearance of the ECG segment. That is very characteristic of digoxin. Another thing that is very characteristic is the shortened QT interval that you can also see here. This QT interval grossly appears quite short compared to what we normally see. And also you can have flattened or inverted or bypassed T waves. So these are all things that we see with digoxin. So if a patient is started on digoxin, you should not be expecting that patient to have a normal ECG. So you'll have all these weird changes that you'll see on the ECG. Other things, you have some degree of PR prolongation because of their blocking effect. Prominent UVS can be seen. Sometimes there'll be a peaking of the terminal portion of the TUVS as well, and some degree of J point depression that we already mentioned. So certain types of electrolyte abnormalities will make digoxin toxicity worse. And one of the things that we do in cases of digoxin toxicity is actually trying to normalize all of these electrolyte abnormalities. And sometimes that is the only thing that is actually needed to bring the patient out of toxicity. That includes hypokalemia, hypermagnesemia, hypercalcemia, and any kind of hypoxia or ischemia. So, whenever you're facing a patient who's having digoxin toxicity, you have to look for all of these electrolyte abnormalities and correct them. So, this is another case of digoxin effect taken this from Tinderly. Here you can clearly see the down characteristic down sloping ST depressions and shortened QT interval. So this is very characteristic of digital toxicity. You can also see a first degree AV block in this particular case. So the problem with the digoxin, and one of the reasons why it has kind of fallen out of favor over the past few decades is that it's a drug which has a very narrow therapeutic index. So it doesn't take much for the patient to actually go into toxicity, and that can lead to all kinds of problems. You can have acute or you can have chronic digoxin toxicity. And the way presentation will vary. So acute toxicity is basically going to be somebody has accidentally taken a huge amount of digoxin, which is kind of uncommon compared to the chronic toxicity that we usually are commonly seeing in the emergency department. The chronic toxicity usually happens when you have a patient who is already on digoxin for the usual indications and now present with some kind of renal failure or volume loss. So in acute toxicity, present more with GI symptoms like nausea, vomiting, abdominal pain. So any patient having these vague abdominal kind of symptoms, nausea, vomiting, and is taking digoxin, then you should have a low index of suspicion to start suspecting digoxin toxicity. And chronic toxicity, on the other hand, you'll have more of the CNS kind of symptoms like weakness, confusion, delirium, coma, etc. And in terms of arrhythmias, you can have any kind of brady or tachyarrhythmias unfortunately. So whereas you do have some certain specific findings that you can have in with the digoxin in terms of arrhythmia, but which we'll come into, but it can pretty much present with any kind. And in electrolytes, hyperkalemia generally it correlates with the increasing toxicity and generally is signifying a worse prognosis. And in chronic toxicity, again, you can have any kind of electrolyte abnormality in the potassium and hypermagnesium as well. So why have I shared this image? Anybody can guess? What does this have to do with our topic? So this was actually a painting which was done by Vincent van Gogh, and you can see that there is a lot of yellow used in this painting. And it is postulated that Vincent van Gogh was actually suffering from digitalis toxicity, and that leads to xanthopsia. So you will see a lot of yellow-green things. And that is why he used to use a lot of yellow in his paintings characteristically. So, which is a theory, and actually, there is not much evidence to actually support that theory, but it is a fun theory, and it helps you remember that digoxin actually does cause xanthopsia. Therapeutic levels for 0.5 to 2 nanograms per ml. More than 2.5 is generally toxic, and levels are usually going to be reliable more than 6 hours after an injection. So, doing it in within that time, we might not get the peak levels. So when do you actually check the level? Patient is on digoxin with any of the following. Patient developing an AKI, patient is sick enough to require also admission or having any other features of digoxin toxicity that we discussed. All of them should ideally get a digoxin level done, even though that is easier said than done in most places. Then, if you have other clinical features suggestive of cardiac glycoside toxicity. So the textbook says that you have in acute toxicity, you should perform levels at 4 hours post injection and then every 4 hours until the toxicity has resolved. And in chronic toxicity, you should perform 6 hours after the last dose and to monitor the steady state level. So practically, we do find it difficult to actually get digoxin level done depending on availability in India. So the normal dose is about 125 to 250 micrograms, and the toxic dose is going to be about 10 times that, so 1 to 2 milligrams. And fatal doses are actually 10 milligrams in an adult and 4 milligrams in a child. So coming to the classic features on the ECG. So classically, you have a combination of an SVT or plus a slow ventricular response. So what the hell does that mean? So basically, you get a combination of there is increased atrial activity, so the paroxysmal atrial tachycardia combined with a slow ventricular response. So you can see the ventricular response is actually so, and you have these premature ventricular complexes as well on top of that. So this very weird looking finding is very characteristic of digoxin overdoses. This is not seen in digoxin effect. This is seen in digoxin overdose. And other things are frequent PVCs, sinus bradycardia, or slow atrial fibrillation. So if you have atrial fibrillation with slow ventricular response, that again is suggestive of toxicity. Any kind of AV block can occur. Another thing that you have to be careful is regularized AF. So if you have atrial fibrillation, which has suddenly become permanent atrial fibrillation that has suddenly become regularized and slow, that is signifying complete heart. So that is another feature of digoxin toxicity. So another, you can obviously lead to VT, polymorphic VT, and there is very characteristic finding of digoxin toxicity that is bidirectional VT. So we will see what that means. So this is one of the cases that I actually presented to our ED. So this is slow AF. So you can see this, it is AF and it's very slow. So this was patient who was having digoxin toxicity. And this is we already mentioned. And again, this is a case where the atrial fibrillation actually got regularized. And this is again actually not a good thing. So this is again suggestive of digoxin toxicity. So anybody can tell what this is? You can type it out in the chat box. What is this? What is this tachyarrhythmia? Yeah, it's bidirectional VT. So it is bidirectional VT. You can see one QRS complex going down, the next one going up. One QRS complex going down, the next one going up. So this is bidirectional VT, very specific for digoxin toxicity, although it can be seen in another condition that is catecholinergic polymorphic VT. So these are the two conditions where this thing is classically seen, but it is very quite specific for digoxin toxicity. Again, we can have we are seeing paroxysmal atrial tachycardia with a slow ventricular response in between a lot of PVC. So you can see lots of PVC in which a slow ventricular response, and lot of PVCs as well on top of that. So this is again characteristic of digoxin toxicity. One of the tricky things about reading an ECG, and this is something that even I have gotten wrong at times, is that it can very closely mimic posterior wall MI. So if you're seeing this in ECG, so posterior wall MI, you commonly have what? You'll have early transition in V2, V2 with large R waves in V2, V3 with the nested depression, which is maximum in V2, V3, V4 compared to the lateral leads V5, V5, V6. So this kind of looks like that, but this is actually all due to digoxin effect. So this is can be one of the pitfall of interpreting an ECG with the digoxin effect, because it can, especially if the patient is coming with some kind of chest pain and all, it can be very difficult to differentiate. So that is one pitfall. Differential diagnosis you can see with any kind of toxicological cause of bradycardia. So CCP overdose, beta blocker overdose, class 1A, 1C, antiarrhythmic overdose, organophosphate poisoning, clonidine overdose, 6 syndrome, and hyperkalemia. So OP obviously will have all kinds of other findings as well. So you won't be actually confused with this. But you can be kind of confused whether it is hyperkalemia or Shukespeare syndrome, because those things can, especially in elderly patients, though these are going to be very difficult to differentiate. So in asymptomatic, coming to the management, obviously any kind of psychological problem, you will start with the ABCDE approach, and the history, physical examination, labs, and all. We'll go in a systematic manner. And any patient with having digoxin overdose will need continuous cardiac monitoring. GI decontamination, you can give activated charcoal 1 gram per kg if the patient is presenting within 1 to 2 hours, but you don't do, there's no real indication of gastric lavage per se. And in symptomatic patients, the initial approach is going to be the same. And coming to bradyarrhythmias, again, routine ACLs, you can go for up to 3 doses of atropine, but this is generally going to only give you a temporizing effect until you can go to a more definitive to manage it. That's your digoxin specific antibody. One thing you have to remember is that you should avoid pacing or beta agonist as far as possible, because it can trigger VT in these patients. So try to avoid these things. So these are some other things that we generally do for unstable bradycardia, but it might actually make things worse than digoxin overdose. Tachyarrhythmias, again, digoxin-specific antibodies is the best possible treatment for these patients. Again, little bit of modification of your usual ACLS, unless the patient is actually really unstable, try to avoid cardioversion as possible for in SPTs as if possible, because it can, trigger VT in this kind of patient. Lidocaine is first line for VT, and as mentioned earlier, all of the electrolyte abnormalities have to be treated like hypomagnesemia, hypokalemia, etc. Hyperkalemia, as I've mentioned multiple times already, is the poor prognostic marker in these patients. And again, the treatment of choice is going to be digoxin-specific antibody. And other usual things that we give for hyperkalemia can be given like insulin glucose, potassium binding resins. You can consider using potassium wasting diuretics plus a little bit of crystalloids, but generally that is not something that I would recommend you doing in the ED right away. But the controversial thing is going to be whether you should be using calcium for hyperkalemia or not. So traditional teaching is that calcium is completely contraindicated in hyperkalemia due to severe digoxin intoxication or similar compounds like oleander, because of it will lead to the stone heart phenomenon. It was theoretical possibility based on some case study that occurred many decades ago. But the literature really doesn't really support that this is actually a real thing. So it probably calcium can be given, especially if you are not actually so sure if the ECG finding and the instability is actually due to digoxin or it's actually due to hyperkalemia. So if you're trying to, if you're erring on giving calcium, it is probably justified. But in a clear-cut case of digoxin overdose, there is no real, what do you call, evidence of benefit from calcium either. So probably if the patient is having digoxin toxicity, it might be best to actually avoid calcium. Although the caveat here is that this is a very controversial topic and there is no real good answer. And again, as I said, always have to correct the this thing, electrolyte abnormality. Coming to digoxin specific antibody, it will bind digoxin in the plasma and it will remove digoxin from your tissues. So it will it is produces improvement in your life-threatening arrhythmias, and dosing is tricky, and you're probably not going to see enough cases to actually know this by heart. So you should always refer when you actually see a patient. But one vial is 40 milligrams, and one vial will bind around 0.5 milligrams of digoxin. So one vial will bind 0.5 milligrams. So when do you actually consider giving this? Life-threatening arrhythmias, yes. Cardiac arrest, yes. Fatal dose, more than 10 milligrams adults, more than 4 milligrams child, yes. Very high levels, more than 12 nanograms per ml, yes. Serum potassium more than 5.5, hyperkalemia, yes. So what are the indications you have to remember? Cardiac arrest, arrhythmias, hyperkalemia, or a very high level or fatal dose. Basically, these are the only 5 main indications for the digoxin specific antibody. Adverse effects is one, allergy can occur. Hypokalemia could also occur with this. And it may actually produce an exacerbation of your underlying atrial fibrillation or heart failure as well. So those are things that we should keep in mind when you actually give this. And another thing is that once you actually give the digoxin specific antibody, the digoxin levels will actually not be that very reliable. So that is another caveat. So how do you actually dose this in a patient who is actually not in cardiac arrest? Then there are two methods. One thing is you can use the suspected injection amount. Another thing is you can use the serum digoxin concentration. By using the suspected injection amount, basically the digoxin body load is going to be 80% of the suspected injection amount. So it's going to be 0.8 times the injection amount. And remember, the one vial is going to of the antibody is going to bind 0.5 milligrams of digoxin. So basically, that amount you have to double that. So 1.6 times the injection amount is going to be the number of vials that you should actually give the patient. That is one method of calculating. Another method of calculating is using the digoxin concentration. It has a little bit more complicated formula. You can again calculate the digoxin body load from the digoxin concentration by multiplying into 5.6 into the body weight divided by 1,000, or you can just calculate the number of vials by multiplying the serum concentration into weight divided by 100. And obviously, this sounds like a lot of fun trying to calculate this. So thankfully, you have easier things that you can do. So in acute toxicity, you can give 2 vials and repeat every hour as required. In chronic toxicity, you can go with half of that. You can go with 1 vial at the start and repeat as hourly as required. And in ACLS, if the patient is having cardiac arrest, this is one of the situations where we will probably be going for a prolonged CPR. And you can go just a go bolus of 10 vials if you have no idea what amount the patient has actually ingested. So rebound. So the half-life of digoxin antibodies around 10 to 15 to 20, sorry, 15 to 20 hours, and the half-life of digoxin is around 40 hours. So theoretically, you can have a rebound increase in digoxin later and leading to more toxicity. And the treatment is actually to actually give more digoxin antibody. So this is something that you should keep in mind, more of an IC level problem than an ED level problem, but another thing that you should keep in mind. And this as a rebound can actually occur very late on, can occur as far as 10 days after the initial presentation. So that is if the patient is having renal failure. Again, this is something that you should keep in mind. And the decision to give more antibodies is going to be based on obviously symptomatology and ECG findings, and not on your digoxin levels, because the digoxin level post administration of the antibodies is not going to be relevant. Disposition, if the medical clearance at 6 hours in asymptomatic patients, if the patient's digoxin levels are falling, normal potassium level, no GI symptoms, or no evidence of the cardiac toxicity, you can consider discharging these patients. If you have given the antibody, then you have to wait for normal serum levels and arrhythmia free time and the patient is clinically well over at least 6 hours before you can actually consider the patient for discharge. So this was all about digoxin toxicity, and the take-home point is to mainly remember the difference between digoxin effect and digoxin toxicity, and you have to remember the indication for digoxin toxicity, specifically antibody, is not just the cardiac arrhythmias, it also includes the hyperkalemia as well. So management of hyperkalemia is also going to be with the digoxin specific antibody in digoxin toxicity. And remember that the assay, if you are able to measure the levels in your institution, they are not going to be very reliable if the patient has already been given the digoxin specific. So that is all about that, and we will pause here for a few 30 seconds for any questions. Otherwise, we'll go on to the next topic. So if anybody has something to add on or ask, they can ask now.
Sir, just 2 or 3 things that I had.
Yeah.
One thing is, what are the chances? At least what I remember is digoxin can cause any arrhythmias except supraventricular arrhythmias. Is that right or is that wrong? That is the first question that I have. Then the second question is, isn't there something like, I don't remember, some boys are asking about what exactly is toxicity and what is digoxin effect in the terms like if the T wave goes above the baseline, then it is digoxin effect. If it doesn't go over the baseline, then it is more likely associated with toxicity. I've heard boys are talking something about this. And the third thing is then if a patient is actually in a bradyarrhythmia secondary to digoxin toxicity and the patient is having some signs of hyperperfusion, apart from giving atropine, we don't have digoxin antibody available with us. How will we treat these patients if we cannot give them something like an epinephrine or pace them for the bradyarrhythmia?
Well, if you are not having the antibody, then you will probably have to give it ADR infusion or something.
ADR infusion. We'll have to proceed with the normal algorithm that we have because we do not have the antibodies.
Yeah, yeah. So that is what. About SVT, it can actually cause this thing. It will increase the
I
BP.
understand the atrial tachycardia with the slow ventricular response, but per se something like a PSVT or an SVT happening with the digoxin toxicity, I think I read somewhere that it is relatively rare. I don't
Yeah,
know.
that's right. It won't go say if with the PR or something. So
Uh-huh.
that is not very typical of the judge. And
Right.
other thing you asked was
Just whether like based on the T wave, whether it
that thing I'm not aware. So like
boys are, I think someone, Praveen sir used to say it can't cause supraventricular tachyarrhythmia. Huh?
yeah, okay, okay.
And
Yeah.
there is something like this, sir. The boys are asked in class that if after the ST depression, if the T wave goes above the baseline, then it is effect, or if it does not cross the baseline, then it is basically a toxicity. Or is it the other way around? I'm not sure. Either one of this is there. Maybe Akshay ma'am can help us with this if she.
I'm actually not quite sure about it. I'll have to check it and get
There
back
in
to
a
you.
textbook also where he has shown the photos.
Okay, okay. Just, let's see if an example here. Ma'am, yes, Salvador Dali is the effect, but
Is the effect?
T
Is the
wave
effect
thing, I'm
doesn't
not sure.
go up? If it does not go up, then it is toxicity.
Uh, this is from Tindinali. It doesn't look like it's going up over
So
the
this is a
T
sign that
wave
it is
here.
toxicity, not a digoxin effect. This is a sign of digoxin toxicity.
Okay, but this was mentioned as a digoxin use in the textbook anyway. So I'm not really sure about that. I'll have to go and check once.
Deal.
It's probably there somewhere in some article. If Boyce said it, it must be true. So because he knows a lot of these things. I'll go find out and
We'll
get
come
back
back.
to you. So